Hi there, my name is Cassandra Cannon. I go by Cassie. I'm a licensed clinical psychologist as well as an EMDR approved consultant and an APA approved sponsor to provide continuing education. And this video is a follow-up video from my most recent video, which was discussing capacity before EMDR work. Today is focusing more on dissociation and evaluating the dissociation patterns that you're seeing. And a major gap that I've noticed in training is you'll be told to screen for dissociation, but then not given specific feedback or information about what you do with that information you got. So a lot of it will be screen for dissociation. If there's dissociation, seek consultation or transfer to someone who's comfortable with dissociation. And not everyone will necessarily need a lot of extra preparation or adaptation based on their dissociative symptoms, because there are dissociative symptoms that are fairly mild and fairly common. And so when I'm evaluating someone, I assume that they dissociate to some degree because we all do. And so I actually, in my mind, created Tier 1 dissociative symptoms, which are the very common non-clinical types of dissociation, and then Tier 2 that could be considered clinically significant that needs a little additional preparation. So for Tier 1, which are the very common types of dissociation, you're going to notice some disconnection with the present based on maybe attention, or if you're stressed or your client is stressed, you might be not as present. If you're fatigued, and then also cognitive overload. And so you'll probably recognize yourself when I give you a few examples, like if you're in a conversation and your attention just starts drifting, or if you're a little bit overwhelmed, you might zone out a little bit, or realizing you missed a part of what someone said, or if you get really absorbed in thoughts or tasks. So for example, I can get really absorbed in a book, a movie, cleaning for some reason. I can get really absorbed in certain tasks. You can also lose track of time during very routine activities. And a really common one is you're driving from home to work, work to home, or somewhere very familiar that you do all the time, and you don't remember most of the drive or parts of the drive. That's very common dissociative symptoms that I'm not really concerned about those getting in the way of processing. Now, the more concerning symptoms really involve disruption in memory, so memory gaps, awareness, identity, and body connection. So examples would be memory gaps and time loss. And obviously we all have some memory gaps, but gaps that are pretty large. And you'll hear people say, well, I don't remember really anything previous to when I was 10 or something. Naturally, we don't really remember much in our very early years, but at some point we are, for the most part, have this cohesive memory of things. If you're seeing, I call them, they're depersonalization and derealization. They're very similar, but for depersonalization, what that means is you don't really recognize yourself or feel connected to yourself or to your body. Whereas derealization, it's like the world feels funny. The world feels fuzzy, funny, and you don't feel connected to the world. You also see identity or ego state shifts, or if your internal family system's informed or trained, you could also see that as parts shifts. And in connection with that, conflicts between parts, and in IFS we call it like polarizations. And you'll also see loss of awareness during sessions with you. So the biggest thing I'm looking for isn't is there dissociation? It's what type is it, and is it going to interfere with reprocessing? And so many clinicians will use the DES2, the mid-60, or the MID. There are other dissociation measures as well. Some are screeners, some require more significant training. I like to use the mid-60 because it gives you a little bit more information and kind of splits things up into domains for you. But they help you identify the presence of dissociation and the general severity. And one thing that I did is I actually then created my own assessment that kind of takes the next step, which is I map the dissociative symptoms that I'm seeing in my clients when they're with me, as well as the symptoms that they endorse on the mid-60. And then I notice the patterns of that. So there are three major patterns, in my opinion. First is intrusion. So what that means is you have too much access to traumatic information. And so the system is really overwhelmed or flooded. And so you'll see intrusive images, memories, emotional flooding, emotions escalating really quickly. And so the thing I'm looking at is, okay, we have too much access to this material. There's not enough containment, which in preparation, remember, we often use a container to assist with that. So the main point to think about when it comes to intrusion is the system is letting more through than it can manage right now. If you see disconnection, which is not enough access to the material, that means that their system is pulling away to protect them. And so you might see spacing out, feeling distant or detached, not being able to be really connected to the information or the material. And they might have a decreased awareness of just themselves or the environment. And so the way I look at that is the system is really protecting by limiting how much information gets through to your client's awareness. And then another pattern, I like to look at it as kind of parts, meaning that the system's organized into these different internal states. And so you might see some internal conflict. I want to address this, but I have all these fears around it. You also might notice that they have different responses to information at different times. And you might notice kind of shifts in emotion, perspective, or behavior. And so the way I conceptualize things is I'm level 1 IFS trained, is that we all have this internal world of parts, and they have different roles and positive intentions for us. And so depending on what is happening in the moment, you might have a different part coming forward. And so sometimes the person might be shifting between different parts based on what's happening in the moment. So it's not that the excess isn't too much or too little, it's divided among different parts. So intrusion, too much access. Disconnection, not enough access. And then parts, that access is divided. And so when it really starts to matter is when you start to see really repeated tier 2 patterns. And so that's dissociation increasing, loss of orientation, they're not able to really stay present. And so that means you need to slow down and reassess readiness. And so what you're doing clinically is you have observed and identified the types of dissociative patterns. If you're seeing that it's mostly the common experiences, which in my mind is tier 1, that's how I've conceptualized it, then most of the time, the simple regular preparation is going to be just fine. If you're seeing more intense patterns, or I call them tier 2, I actually have my dissociation pattern tracker and clinical guide. I have it split up between identifying the pattern, what are the indicators. So we have the common dissociative experiences, and then I have the clinically significant patterns, which are the memory continuity and detachment from self, so depersonalization, derealization. and identity and self-state shifts, memory monitoring difficulties, somatic dissociation. So those are the ones where you're going to need to really evaluate how intense is this and what level of preparation do we need to engage in. I'm separating addressing dissociation in the preparation phase, and I'm separating that from what you do when you are reprocessing. So you've already done all the prep you need to do, and they're reprocessing, and there are different things you do during that phase for reprocessing to help with the dissociation. But today we're just focusing on the prep, how you get them ready to reprocess. So if you've identified that your client is having those intrusion patterns, so they're having too much information come in, you want to help them with containment. And if you're noticing that there's a lot of disconnection, so they can't really access, then you're helping your client stay present and connected. And if you're noticing a lot of ego states or parts interfering, and you could also look at this as someone who may have dissociative identity disorder, and then you're working with that internal organization and cooperation among ego states or parts. So, for example, with disconnection, a very simple starting point might be just bringing your client's attention back to the present. So these might look like orienting to the room, naming objects, reconnecting them to where they are right. If you're familiar with the SIPOS procedure, which the intention is to constantly bring your client back and then strengthen their present awareness. You know, how many paintings do I have in my office? Or count the pillows in my office. Where are you right now? And then enhancing that with slow bilaterals when they're able to reconnect to the present. So it's a very basic example, but it shows how that intervention matches the pattern of what's going on with that dissociation. And so kind of taking the 30,000-foot view, you don't start with an intervention because you don't know if you're actually connecting the right intervention to the right problem. So you have to identify what kind of dissociation it is. And once you identify that, then you're going to use particular preparation procedures to then strengthen your client's ability to be successful in long-term reprocessing. So this is where many clinicians get stuck. They know there's dissociation, they don't know what to do about it. So because if you know me well enough by now, I like to have things operationalized and very clearly organized. I have created my own dissociation pattern tracker and clinical guide. I already showed you the different pages that help you identify the pattern. And because sometimes in the moment I'm so absorbed with my client, I might need, oh, I'm seeing this, but off the top of my head, I might not necessarily know right away which tool I need to use. So I actually mapped the different issue you're seeing, the pattern, so the symptom, the pattern, the tier, the clinical interpretation, and then the preparation focus. There's a couple pages of this based on the material. And it helps you, so for example, memory continuity or gaps in time loss. So that helps you know that there may be some compartmentalization, some ego states. And so you would strengthen present orientation, use grounding, consider SIPOS, and focus, if you need to, on IFS or ego state therapy. And that would be for someone who you think has symptoms of dissociative identity disorder or might actually meet the full criteria. I hope that this fills that gap of, I have dissociative symptoms, I don't know what to do with it. I hope that gives you that confidence to be able to move forward and getting your client prepared to do EMDR. If you do this at the beginning of your EMDR treatment with someone, you're much less likely to run into problems later on. And you're much less likely going to need to track because this will already be done first. Thank you very much for spending time with me.